Hello. So thank you very much for taking time out of a patio barbecue afternoon and joining us for the BCIT P&O Student Research Symposium. So for the schedule today, we've got three presentations from our students, followed by a refreshment break, and then followed by another three more presentations. So I'd also like to acknowledge a lot of our live stream audience. So we see a camera set up around us. That's because we have about 15 to 20 individuals that are joining us via live stream. So I'd like to say hello to the camera and welcome all of you, and thank you very much for joining us as well via live stream. So without further ado, does Jason have any?
Sure, I just want to thank everybody for coming out, especially on a beautiful evening like this. And if we could arrange a patio next time. It seems to be consistently a really sunny, beautiful day to do this, so that's a great thing. But thank you for coming out and supporting our students tonight, and look forward to fantastic presentations and good collaborative discussion throughout as well. It would be wonderful. Do we have a thank you slide? At the very end, we had some thank yous, but we're good. All right, so I think, because we're already a couple minutes late, do you want to start out with the first two? We have Sam, and where's your partner?
Rachel.
And Rachel, coming from the side? I'm like, wow, that's impressive. All right, guys, so thank you. Take it away.
I know there's been a couple thank yous already, but I just wanted to thank everyone for being here on behalf of the class of 2018. It's really great to see all the support for our research we've done over the past 2 years. My name is Sam Spencer.
And I'm Rachel Rudolph.
And we will be presenting today on our topic, which is titled Interprofessional Collaboration, or IPC for short, between clinicians and engineers. Benefits, barriers, and facilitators. Okay, so just a quick outline before we get started. First, we'll go through why we chose to do this project. We'll give you a bit of background info and then into our methods and results, and we'll be working some recommendations in there as we go. So, why we chose to do this project. I'd like to just start by asking two simple questions. The first is, have you ever had a design idea but didn't know where to go from there? And the second, have you ever seen a product and thought that it could be improved in some way? So, this is two questions that Rachel and I actually both experienced even just in the short amount of time that we've been in this field, and it's what initially sparked our curiosity for this project. The first question is kind of an indication of a lack of collaboration taking place. So there's an idea there, but there's no teamwork happening and there's no collaboration taking place. The second question is, it kind of wraps around this idea that there may be a collaboration taking place because there is a product on the market, but if it could be improved, and that's an indication that there might be some improvement to be made with that collaboration as well. Which brings us to our objective. To investigate the primary barriers and facilitators to collaboration between P&O clinicians and engineers involved in prosthetic and orthotic technological development. And I'll hand it over to Rachel to give you a bit of background.
All right, so initially we performed a literature review and were unable to find anything specific to P&O technological development. Therefore, we had to take a step back and we had to look at interprofessional collaboration between us and the healthcare profession. So this might look very familiar to many of you in the sense of working with occupational therapists or physiotherapists. So what we know from this type of collaboration is that there are benefits, such as improved patient outcomes and having multiple perspectives on the team. But despite these benefits, there are also barriers, lack of time or lack of self-efficacy that can really halt the collaboration process. But we also know that there are facilitators that, when implemented correctly, can improve the collaborative process and result in more successful outcomes. And by facilitators, I'm talking about factors such as motivation or a cohesive team, or even in terms of a person having a project leader or a mediator. In order to see whether this type of collaboration, that what we know from healthcare also applies to P&O technology, we took a mixed methods approach to our research study, in which we had a quantitative and a qualitative aspect. So our quantitative aspect was an online survey, which we then followed up with an interview for our qualitative aspect. So as I mentioned, our first step was a survey. And the purpose of this really was to explore the benefits, barriers, and facilitators of interprofessional collaboration within P&O technology. In order to get an idea of how this collaboration is currently existing, we wanted to see both the perspective of P&O professionals as well as the engineers. And when I talk about P&O professionals, I'm talking about clinicians, technicians, residents, as well as students. In terms of recruiting these participants, we recruited our P&O participants from professional member directories such as OPC. And then in terms of recruiting our engineers, and this is also a limitation of our study, due to the fact that we are both involved in P&O as well as only students, our engineering professional network is quite small. Therefore, we had to use word of mouth or what we had developed over the past 2 years. Our survey consisted of 39 items total, in which 37 were closed and ranked on a 5-point Likert scale, which we then compressed to 3. We had an additional 2 open items, which the first was to explore any barriers that we may have missed, and the second was to explore any possible facilitators that people have experienced or would have liked to suggest. In terms of our analysis, we are really interested in whether there is a difference in perspective between the group that has experienced interprofessional collaboration and the group that hasn't. And in order to analyze this, we looked at non-parametric descriptive statistics, specifically the Kruskal-Wallis test, to test for significance. So this is our demographics of our survey here. We had a total of 102 responses, which we're absolutely thrilled about, so thank you so much for participating, for those in the audience that did. To break this down a little bit further, we had 50 for P&O professionals, which again is the clinicians, technicians, residents. And then we had 26 students on the P&O side, as well as 12 engineers, 4 engineering students, and additional 6 participants that we had to exclude due to not meeting inclusion-exclusion criteria, which left us with a total sample size of 96. The first domain in our survey looked at the benefits of interprofessional collaboration. And what we're able to find in our survey is that 95% of people felt that interprofessional collaboration was a beneficial endeavor for P&O. And they listed the top 3 reasons as improved patient outcomes, the ability to gain from others' experience, as well as the promotion of innovation. We also found that 73% of our participants actually thought that having a successful collaborative process was more valuable than achieving an end goal. And Sam and I found this point very interesting as we began to explore some of these facilitators, because the purpose of our study is really looking at how we can improve the collaborative process. The next domain of our study looked at collaboration experience. And what we were able to find is that 53% of our participants had experienced collaboration. And within this group of people, 60% have had more than 10 years of experience. This left the remainder of our sample, which is 47% of our sample, as the no experience group. And what we were able to find from this group is that 84% of these people are interested in collaboration, which is really exciting. It's great that people want to get involved. However, we only found that 5% of people have actually sought out collaboration. There's a big difference in these numbers, and we wanted to look at this as we went through our survey as our interview and reasons why this might be. The next domain of our survey looked at barriers. And as I explained earlier, we broke this down into 2 groups, our no experience group and our experienced group. Which brings us to our first figure. This is the net agreeance of barriers from our experienced group. So what you're seeing here on the y-axis is the agreeance in a percent value, and on the x-axis is a list of the 16 barriers which each participant ranked on the 5-point Likert scale. So you're probably wondering why we went with percent agreeance. And the reason we did this is we wanted to see as a weighting whether people were leaning more towards the agree side or the disagree side. In order to calculate this, we used a net agreeance formula in which we took the number of participants that agreed, we subtracted the number that disagreed, divided this all by the total sample size, and multiplied it by 100%. So what we're looking at here is everything above 0, there's a net agreement, meaning that more people agreed than disagreed, and everything below 0 is a net disagreement. So for example, if we look at time as a barrier, which is the one on the very far left, we're seeing that there's a 65% net agreement that time is indeed a barrier. In contrast, if we look at the risk to reputation, which is on the far right, we're seeing that there's a 50% net disagreement that this is a barrier to collaboration. But we'd like to highlight for you our top 3 barriers which came up, and that was time, expense, and logistics. Now this is our net agreeance of barriers from our no experience group. So we're seeing the same y-axis and x-axis, but on a global level we see that there's more of a net agreeance of barriers versus the no experience group. But we still see the top 3 barriers, which is time, expense, and logistics. Now there is one barrier that came up as statistically significant, and we found this to be really interesting, and this was the barrier of lack of opportunity. So this is again back to our experience group, and what we saw in our survey here is that there's a 10% net disagreement. This is a barrier, meaning that those who have experienced collaboration don't actually see lack of opportunity as a barrier. In contrast, in our no experience group, we see that there's a 35% net agreement that this is a barrier. The last domain of our study looked at facilitators, and this is our second open item on our survey, and this is really what links our survey to our interview, as this is what we wanted to explore further, and which Sam is going to talk about.
Great. Yeah, so like Rachel mentioned, this last item on our survey was about facilitators, and it was open. So we basically just asked all of our participants to list any additional facilitators that they thought were relevant to this experience. What we did is we came up with 3 themes based on those responses. The first one is opportunity, which is essentially what it sounds like. It's just what items are around that can be created and used to create opportunities to collaborate. The next one was attitudes. This is a bit of a harder one to describe, but it essentially describes the intangible items, the way that people think about collaboration, the way they approach it, and the attitudes that they have towards collaboration. And then the last theme that we came up with was action, which is those more tangible items, the things that can be actioned on in order to create collaboration opportunities. So what we did, we used that to inform our step 2 of our mixed methods, which was our interviews. We did 30-minute interviews that were semi-structured in style. So we had a script, but we allowed the participants to deviate from that whenever they wanted. And we interviewed 9 participants. So we purposefully sampled here so that we could get a really wide variety of opinions and backgrounds. And we ended up with 5 people with a clinical background and 5 people with an engineering background. 2 of those actually were dual certified, so they had both engineering and clinical perspectives, and 2 of those were students as well. We did a qualitative analysis on that data by transcribing the audio and using in vivo software. So just a little closer look at our analysis is we started off with 4 themes. 3 of those themes were the ones I just listed: opportunities, attitudes, and actions. And then we added a 4th theme as well, which was benefits, which, as Rachel mentioned already, was another significant portion of our survey. What we did is we highlighted any references to those themes in our text by doing a deductive content analysis. And what we did is we highlighted that text separately, and we did a cross-analysis after that, where we came together and made sure that we were on the same page with what we were looking at. And that gave us 349 references, so those are highlighted pieces of text that we felt were relevant to those themes. From there, we did an inductive content analysis, where we took all of those 349 references and we grouped them together into sub-themes that we thought were kind of relevant or belonged together into those sub-themes, which left us with 79. What we did from there is we did a frequency analysis where we took the amount of times that those sub-themes were spoken about, and that way we were able to equate a bit of importance to what those messages were. So for results, as you can see on the top there, we have our 4 main themes to start out with, and we're going to start with benefits. So this is a word cloud that describes the sub-themes, so those words that describe different references to benefits in the transcripts. And the larger ones are the ones that are more important, so to speak, because they were most frequently talked about by our participants. Because of time, I can't go into all of them, so I'm just going to focus on the bigger ones. So the major benefit that we found from our interviews was that collaboration, you benefit from multiple perspectives, which is really no surprise when we're getting team members from multiple different areas of expertise. We do benefit from that multiple perspectives that they bring. The more interesting benefit, I think, to bring up is the one just down and to the left, which is efficiency. This is really interesting because time was listed as our #1 barrier from our survey. And efficiency is kind of flies in the face of time. So one of the participants put it really well this way: "I'll never know enough, or it will take me years to learn what someone already knew, and I can just give you the key things that you need." So what they're essentially saying here is that yes, it takes time to collaborate, but you essentially save time over the long run by benefiting from other people's experience and not having to teach all of that to yourself. So moving on to our second theme is opportunity. Like I say, this is the idea of we're trying to foster collaboration and create opportunities for those who are interested. As you can see here, there's 2 terms that are much bigger than the others, so we'll focus on that. The first one is initiative. Now this is talking about taking initiative when opportunities arise to actually create that collaboration and act on it. This was something that a lot of our more experienced participants talked about. Another thing that the more experienced participants talked about a lot was this idea of organic, which is essentially speaking to the fact that they actually didn't seek out collaboration. So while some of the participants in our survey felt that a lack of opportunity was a problem, but they weren't seeking it out. And neither, in fact, were our more experienced participants as well. So we have a quote to kind of sum that up too. You need to wait until a problem comes up, and when it is there, say, oh, I know so-and-so in this field, and so with this expertise. Let's try to get everyone on a call or whatever and bounce some ideas back and forth. So this is actually describing both of those ideas. They're organically waiting for the problem to show up, but when it does, they're willing to take that initiative and get a group together to collaborate and solve that problem. So our third theme is a really big one. It ended up being much bigger than we expected, and as you can see by the amount of terms on the screen, attitudes doesn't quite adequately sum it up. So I'd like to just draw your attention to the two big ones there, one of which is discipline-specific knowledge. This is an attitude that a lot of our participants expressed, just knowing that because people are coming from a variety of different backgrounds, there is an attitude of knowing that there's discipline-specific knowledge that each person brings to the table, and that, again, is one of the benefits to collaboration. The other interesting one is knowing your limits, because it speaks to a certain amount of humbleness that our participants had, and it was summed up really well like this. The mistake the prosthetic and orthotic profession has made historically in my time is to somehow think that we knew we're good at everything and we don't need to talk to anybody else, and that's a huge mistake. And this was a sentiment that was brought up repeatedly by our more experienced participants. They were essentially just saying that we need to know what we don't know, and only then can we fill the holes and try to look to other professions to benefit from their expertise. So our last one is actions. This, like I say, is more actionable items. It was, again, a really big topic, so we'll focus on the biggest one there, which is understand your problem. Our most experienced multi-professional put it really well. You have to have some patience to get enough experience with it, not try to come to a solution before you have enough knowledge. So if we're looking back to time as our #1 barrier again, this is another really great way to try to save time. What he is essentially saying is that if we have the patience to understand the problem right off the start, we don't have to waste 6 months of our time to come up with a solution that doesn't work. So understanding that problem in the beginning saves time in the long run. So lastly, we have a couple additional comments. These ones were not necessarily really frequently brought up, but they were really relevant to our topic, so we decided to bring them up anyways. The first is a common language. I think this is really important for when we have multiple people from different disciplines that each have discipline-specific knowledge. We need to use common language so that we can communicate effectively. The second is association involvement. I was really pleased to hear that in the OPC conference 2 years ago in Banff, we had actually had a collaboration-related seminar, which was really great to see. And I'd love to see more of that happening because we need the support of associations to continue creating these collaboration opportunities. The third is an online platform. I think this is a really actionable item that I think could be created literally overnight with the amount of technology that's around these days. Creating an online platform such as a LinkedIn profile or something like that where people can log on and intentionally network to collaborate on different projects, I think is a great way to go. The fourth is conferences and events. Now, I'm not talking about the OPC one that I just referred to before, but I'm talking more to conferences that are specifically geared towards collaborating towards problems. This can be events as well. So for example, last year in September, we had a make-a-thon at the Carey Institute. It was super effective to bring different professions together, and we'd love to see more of that happening. The last one is we'd like to acknowledge that there is a difference between research and industry when we're talking about collaboration. This was something that was brought up by the multi-professionals in our field. And essentially, research is a more curiosity-driven and more academia-driven pursuit, whereas industry is a bit more of a business-centered model. So while collaboration can happen in both of these different settings, we do acknowledge that they are different, and they probably warrant research as sort of separate projects, which brings us into our future directions.
So the first future direction we'd like to talk about is we would like to focus on each of those 4 themes that Sam mentioned earlier. So we described that our theme of attitudes really became way more than we ever expected it to be. So we would like to take a deeper look into that and really kind of explore that and see what we can gain from that. Additionally, we would like to focus on the engineering side. It became very apparent through our interviews. Collaboration became so well integrated into the engineering field, all the way from being a student to working in a professional workplace. And we think there's a lot that can be learned from this group of people. We also would like to focus on the technicians. We'd like to acknowledge that there is a difference between clinicians and technicians in terms of what discipline-specific knowledge can be brought to the table, and we believe that they are an interesting profession to look at, as they might be able to mitigate the gap between the engineers and the clinicians. We also want to look at why that no experience group wasn't seeking out interprofessional collaboration. Is it because of some of these perceived barriers, or is there other things that we don't understand that are happening? And we'd like to leave you with a few final notes, and these are some quotes that we find were very valuable from our discussions. The first one being, if you're ever going to be successful, you need to know what a value proposition is, and you need to be able to articulate it. What is the value that you bring to other people? And I think this is really important to recognize, that we all have discipline-specific knowledge, and we can be very valuable to a team. Therefore, don't be afraid to take that first step and work with another group of people. And the second quote is, collaboration is a two-way street. We think of collaboration as what can you do for P&O, but we also need to understand and think about it as what can P&O do for you. And this is really speaks to working together on a team to improve patient outcomes, because that's what it really all comes down to, is improving our patient outcomes. At this time, we'd like to invite any questions from the audience.
My name is Tanis Thiessen, and this is my partner, Russell Beezer, and tonight we're talking about the patient's opinion of outcome measures used during treatment appointments. This evening, we're going to go through our research study with the background, methods, results, followed by discussion, conclusion, and suggestions for further research. So it's no surprise that the use of outcome measures is increasing in the field of prosthetics and orthotics. Many researchers, insurance companies, and now patients are starting to demand the use of outcome measures. Our study aims to assess whether patients see outcome measures as a beneficial, or see the benefits of using outcome measures, and whether they see outcome measures as a beneficial use of their time. There's currently many references stating that the routine collection of patient-reported outcome measures enhances the patient-provider communication and improves the patient satisfaction. There's also research now out stating that outcome measures can also improve the monitoring of treatment response and the detection of unrecognized problems. So research into the use of outcome measures is not new in the medical field, and neither is the study of the patient's perspective of the use of outcome measures. However, there is a gap in the current research when it comes to prosthetics and orthotics specifically. And so this is where we decide to step in with our research project to try and fill this gap.
All right, so for the methods of our research, what we did is we developed an online survey using an online survey platform. And within that platform, we created questions, two sets of questions. One for the outcome measure group, or patients who are familiar with outcome measures. And then another set of questions that was made specifically for patients who are unfamiliar with outcome measures or the term outcome measure. Once we developed the survey, we then emailed a link and description of the survey to Orthotics Prosthetics Canada, after which OPC then in turn delivered or emailed the survey to all registered clinicians across Canada. So you did receive that email. Once the clinicians received the email, they delivered the survey and description to their patients. Now, the patients had approximately 6 weeks to complete the survey, but it's important to note that not all clinicians and not all patients that were contacted participated in our research. And as well, participants or patients were self-selected.
So just to go into some further detail about our survey itself, we had 17 respondents complete our survey. The first section of the survey included demographics about each of the respondents, and all 17 respondents filled out this part of the survey. Patients were then asked, does your clinician use outcome measures with you? Where they were given the option of yes or no, and based on this option, it guided them to their designated stream. So we had 13 respondents report yes to this question, and they were directed to the questions talking about their experience with outcome measures. Some of the content included motivation, feedback, and the time spent on the use of outcome measures. And like I said, we had 13 of 17 follow this stream. Then there was the stream of no. We had 4 participants follow this stream, and it asked questions about their feedback through their treatment process. Both groups experienced similar questioning, but for the patients that had responded no, the word outcome measures was omitted from their questioning, so they were asked about feedback. Just to give an example of how these 2 streams were separated, here's some sample questions. The domain here, we were asking about motivation. So patients who had experience with outcome measures, they were asked, do you find outcome measures motivating? And the patients that had no experience with outcome measures were asked, is it motivating to see your progress through your treatment? So they were similar in the question that we were asked, but the wording was different.
For the demographics of our research, of the 17 participants, 9 of them were male, 8 of them were female, with the majority of them residing in British Columbia. These are the age ranges of the participants, with the majority falling under the 40-plus category. As well, the majority of them were patients for under 5 years. Based on our questions, the results were organized into 2 themes, the patient-clinician communication and the effects of outcome measures on the treatment process. 76% of the participants reported that that their clinicians were using outcome measures with them. 92% of the participants reported that they had received feedback about outcome measures. 92% of the participants also reported receiving instruction about what outcome measures were and what they were used for. And 77% of the participants reported that they wanted to learn more. On a scale from 1 to 10, the respondents reported or rated on average 8 out of 10 for a feeling of involvement in their rehabilitation process. And 100% of the participants reported that they would like to receive feedback on their progress. These 2 questions were asked on the survey to the 13 participants who were involved with outcome measures. And they were also given the opportunity to select all that apply. So when asked about their concerns or what they did not like about outcome measures, 7 of them selected none of the above. And when asked about their feedback preference and how they were preferred to receive that information, 12 reported that they wanted it verbally explained to them, and 10 of them reported that they wanted a printed out or written out report. In regards to the treatment process, 100% of the participants responded it was motivating to use outcome measures and to see their progress. 85% responded that outcome measures helped their rehabilitation process. And on a scale from 1 to 5, participants rated 4 out of 5 for outcome measures being a good use of their time. Now, 9 of those participants reported that they would not change the amount of time dedicated to the use of outcome measures. 2 of those patients reported that they would increase the amount of time dedicated to outcome measures, and 2 of those also reported that they would decrease the amount of time dedicated to outcome measures. Patients were also asked how much of their treatment time they would like to dedicate specifically to the outcome measure process in their clinical time, with the majority reporting that they wanted to dedicate 5 to 10 minutes to outcome measures in their clinical time.
So to just go into some further detail about the results that Russ had just reported, We asked the patients if they found outcome measures to be beneficial for their treatment process, and all respondents reported that it was beneficial, either very beneficial or somewhat beneficial. We then further separated the groups into how long they had been a patient for. And as we can see from our results, it appears that patients who have been patients for a less amount of time found outcome measures to be more beneficial than those patients that had been in P&O for longer. One theory to explain this trend is the use of outcome measures in other medical fields. As we see the trend of the use of outcome measures going up in other fields such as physiotherapy or occupational therapy, we believe that the patients recognize outcome measures use more in the field of prosthetics and orthotics and further see a benefit. Another theory that could explain this is newer patients require more feedback with their treatment, as all of the information is now new to them, and they require that feedback, and the outcome measures can help with that process. So for communication, based on our findings, we found that outcome measures is a useful tool for patients when it comes to feedback. It opens up an avenue for communication with their clinician about their progress, and it can also open up communication about other problems or further discussion into their treatment process that go beyond the outcome measure itself. This enhances the patient and clinician interaction and opens up even more communication. Also, based on our findings, we found that patients find an interest in outcome measures as well. So they want to know about their progress, and they want to know what outcome measures are used for, which show that patients want to see their progress, and outcome measures can also help with that. With the treatment process itself, outcome measures allow both the clinician and the patient to see their progress or lack thereof. This allows the clinician to further tailor the treatment process based on that individual patient, and also based on these results. Also, patients find the outcome measures to be motivating. We had 13 out of 13 respondents report that outcome measures were motivating for their treatment process, as well as 13 out of 13 found that it was helpful in their treatment process as well. So another benefit within the treatment process itself. And for treatment time, patients do want to dedicate time to outcome measures. We can see that from our results that the majority wanted 5 to 10 minutes to outcome measures, so they do see a benefit as it's used in their treatment time.
So we did want to highlight a few limitations to our research. One being the email distribution. Now we understand that clinicians may be receiving a lot of emails and surveys from OPC, which could result in some survey fatigue. Okay, so moving on to the potential bias. So we realize that there's a possibility that clinics and clinicians who are involved in the outcome measure process day to day could be or are more likely to participate in our study. As well, there's a possibility that those clinicians are choosing patients that are very experienced with outcome measures. And then the incomplete surveys we wanted to highlight. There was no requirement to complete our survey. So as a result, some patients decided not to complete all the questions.
So we find that the use of outcome measures is a really important topic, especially in prosthetics and orthotics as it grows. And we would love to see our research be taken further with other avenues, and we do have some suggestions for that further research. First, random selection. So we do have a list of all of the clinics from OPC, and we believe that it would be more beneficial to the study if we could randomly select the clinics that were involved in the study. As well as within those clinics, it would be more beneficial to randomly select those patients, and that way we can reduce the potential biasing of patients doing this survey that may have more experience than others. And through this strategy, we believe that you can gain a larger sample size. From this, we can have more statistically significant results, and then we can make more generalized statements across the general population of prosthetics and orthotics. We'd also like to better manage the method of distribution. Like a game of telephone, the more people that get involved, the more the information can be lost. And it would be more beneficial if we could distribute the surveys directly to the patients and take out the middleman. And lastly, we think it would be interesting to look into how other professions see outcome measures in the field of prosthetics and orthotics. It'd be interesting to see how possibly surgeons or insurance companies view the use of outcome measures. So in conclusion, based on the patient's responses, there seems to be a trend towards patients seeing a benefit to the use of outcome measures. Although our sample size was small, the trend appeared to be in favor of the use of outcome measures for both communication and for monitoring of the treatment process. So we recommend that there's the implementation of outcome measures in clinical practice among all clinicians. Research already shows that there is a benefit to the use of outcome measures and that outcome measures are beneficial for clinicians. There's also research now showing which outcome measures could be more beneficial for specific populations within P&O. And now through our research, we can see that patients want to know about their progress, and they find that it's motivating to see. Patients want to learn more about outcome measures and what they're used for, and this can help guide the patient into making more informed clinical decisions and enhancing their health literacy. By knowing what outcome measures are and what they're used for, they can be involved in the treatment process and be empowered to make decisions with the clinician. And lastly, if we truly are making a patient-centered care plan, the patient needs to be involved in the treatment process. And I believe that outcome measures is a great way for this to happen. So thank you for listening to our presentation. We'd now like to open up the floor to any questions.
All right, so once again, thank you for being here. My name's Sydney Stocco,
And I'm Jordan Schwartz.
and the title of our capstone is Serial Casting versus Dynamic AFOs used following botulinum neurotoxin injections, and this is a pilot study. So just a quick disclosure, the dynamic stretching, thank you. The dynamic stretching AFOs that we used for this study were provided to us free of charge by Ultraflex Systems, which was great. It was very kind of them. None of the researchers involved in this study received any sort of financial compensation over the progress of this study.
So to provide a quick outline of what we'll be talking about today, we'll talk about the background, rationale, and purpose driving this study. We'll explain the methods that we use to collect our data. We'll talk about the results of this data and provide some of the challenges that we encountered along the way, along with some take-home messages and future directions of where we'd like to see this research headed in the future. So first and foremost, we understand that botulinum neurotoxin is considered the gold standard in terms of spasticity management. Following an acquired brain injury, oftentimes patients present with high muscle tone, which can be kind of knocked out with botulinum toxin injections acting as a nerve block. We also know that botulinum toxin injections provide a window of effectiveness where you can use stretching therapies in conjunction with these injections to provide further benefits. So a recent systematic review has shown that adjunct therapies to botulinum toxin injections do provide better patient outcomes compared to using botulinum toxin on its own.
So the rationale for this study was twofold. So first off, as Jordan mentioned, there is a lack of evidence comparing these stretching therapies directly to each other, although there is some body of evidence showing that they work compared to no stretching therapy. So we felt it was interesting to select two and to compare them directly. Secondly, this is the continuation of a feasibility study that was done by two graduating members of the 2016 class, so Melina Rappaport and Amanda Bremner. Conducted a feasibility study in 2016 at the same clinic where we conducted our research. We were able to take the results of their feasibility study, make a few changes in order to more easily integrate it into clinical practice. So this is sort of the second stage of this topic. So the purpose of our study is to compare the effects of these two stretching therapies following the injection of botulinum neurotoxin type A into individuals with acquired brain injury, and this is a pilot study, as I mentioned. The two therapies that we've chosen were serial casting and dynamic AFO. So on the left we have an example of our serial cast, and on the right we have an example of the dynamic AFO from Ultraflex. The dynamic AFOs were custom made based on casts taken by a local orthotist, and they were centrally fabricated. And the serial casts were applied for up to 10 days at a time.
So in order to kind of guide the research process that we use to look at these two different stretching modalities, we decided to use the World Health Organization's International Classification of Function, Disability, and Health. So the ICF is broken down into three components, which are the structure of the body, the body's function, as well as activity and participation. So following an acquired brain injury, patients often present with lower limb spasticity, which causes an equinus foot positioning. So in terms of the structure of the ankle specifically, there's reduced mobility along with muscle spasticity in the gastrocs and the soleus. In order to measure this, we decided to use the dorsiflexion range of motion along with the modified Ashworth scale. So the dorsiflexion range of motion is something that is collected as part of every assessment, and the modified Ashworth scale is a commonly used measure of spasticity. Both of these outcomes take only a few seconds to complete in the clinic. Looking at body function, we know that acquired brain injury causes effects on gait. So because the function of the ankle specifically, the body structure of the ankle is affected, this poses limitations in terms of ambulation as well as inefficiencies shown through gait. So in order to measure this, we used the 10-meter walk test, which is shown to be a valid measure of ambulatory capacity. In terms of measuring participation and function, we decided to use the goal attainment scale. Now, measuring difficulty with ADLs as well as limited engagement in the community is something that is a little bit more difficult to do objectively. So we used the goal attainment scale, which we'll talk a little bit about later on in the presentation, but we believe that it does a good job of measuring participation and activity.
So our patients were recruited from the New Westminster Spasticity Clinic. They were identified by the on-site physiatrist who was providing botulinum neurotoxin injections at this clinic, and they were enrolled into our study by the on-site orthotist. So this was a great location to run this study out of. It was a multidisciplinary clinic, so we had all of those professionals under the same roof, which was really nice as far as trying to coordinate and organize. And the ethics for this study was done through the BCIT Research Ethics Board. So participants from this study, they were all consenting adults, so over the age of 18. They were provided with a written consent form. Our patients had undergone an acquired brain injury at least 6 months previous, so we were trying to avoid the acute phase of ABI recovery, which would involve avoiding that period of flaccidity immediately after an acquired brain injury. And these patients all had a hemiplegic spastic presentation, so they were ambulatory, and they just showed that hemiplegic sort of presentation. They needed to be candidates both for the botulinum neurotoxin injections and for either of the stretching therapies. Exclusion criteria, we chose to exclude patients who had had an ABI before the age of 2, so this effectively excluded cerebral palsy patients. Our reasoning behind this is that for those individuals who have cerebral palsy, they typically don't get the chance to develop normal gait patterns the same way that someone who has an acquired brain injury later in their life would. So we wanted to sort of look at individuals who had already developed those central pattern generators and see how they were affected by this incident. We also chose to exclude individuals who'd received botulinum toxin injections within the previous 6 months. Literature on botulinum toxin shows that there is a 3 to 6 month window within which the injections are active, so we wanted to be able to avoid any sort of effects from previous injections.
So following participant identification and recruitment, participants were provided with a document that outlined the potential risks, the benefits, along with the study protocol that we were implementing. The pre-treatment measures were taken following consent from our participants, and these were taken by the orthotist who was also providing treatment. And then botulinum neurotoxin injections were administered via ultrasound guidance by the physiatrist on site. After a period of 1 to 4 weeks waiting for the botulinum toxin injections to take effect, patients were randomized either into the serial casting group or the dynamic stretching AFO group. Participants were treated with either one of these stretching modalities for a period of 4 weeks, after which post-treatment measurements were taken at a follow-up appointment by the orthotist. So the orthotist was the one who was providing treatment as well as collecting data for this study, and we were able to run 4 participants through the study protocol. Data was complete across all outcome measures for all 4 patients, and we believe that this indicates that our methodology is effective for use as clinical research. It's also important to note that there were no dropouts and no adverse events reported throughout the study procedure.
So jumping into our results, so we did get complete data sets from all 4 of our patients, which we were very, very happy about. We'll start with range of motion data. So this is looking at passive range of motion at the ankle with the knee extended. So we have our AFO group are the 2 patients on the left, and our serial casting group are the 2 patients on the right. Obviously, with a sample size of only 4, we're not able to sort of decide on any definitive conclusions, but we think that this data is really great to have. We did have 1 patient in each group show a fairly substantial increase in range of motion, and 1 patient in each group who did not show much or any improvement in range of motion. So data is a little bit mixed on range of motion. Looking at our 10-meter walk data, similarly, we have 1 patient in each group who is showing a more substantial improvement in their 10-meter walk score, and 1 patient in each group who is showing little to no improvement. So for the 10-meter walk score, a substantial meaningful change in speed is defined as an increase in speed of 0.1 meters per second. So we did have 1 patient in the AFO group, patient number 2, who showed an improvement in speed of 0.21 meters per second, so that was really great to see. And we had 1 patient in the serial casting group who showed a small meaningful change of 0.05 meters per second. So once again, 1 patient in each group who showed some improvement and 1 who did not.
So looking at data collected from the modified Ashworth scale, it's valuable to note that all 4 of our patients started with a modified Ashworth scale score of 3, which indicates considerable increase in muscle tone where passive movement is difficult. Following the 4-week stretching modalities, we saw 1 patient in each group again who showed an improvement to a score of 2 on the modified Ashworth scale. So this indicates that muscle tone is still present through range of motion, but the affected part is easily moved. So this is clinically important as being able to easily move the ankle joint could mean the difference between achieving foot flat at mid-stance or a braceable position at 90 degrees. Looking at data from our goal attainment scale, this outcome measure might be something that isn't as familiar for those of you working in clinics. So I'll provide a brief example of how this outcome measure works. So let's say you have a patient that comes in talking about how she is unable to take her dog for very long for a walk. She makes it part of the way down the block before she has to turn around and head home. So this would be scored at a -2, which is the baseline for the goal attainment scale. So maybe the orthotist would help her create goals that fit along this scaling system where a -1 is being able to walk for 10 minutes with her dog. An expected level of outcome, so her goal for treatment would be scored at a 0, and this could be walking all the way to the park with her dog and making it back home, so this could be a 15-minute walk. A +1 score could be making it to the park, playing fetch with her dog for a little while, turning around and coming home, and 20 minutes of walking. Finally, the best possible outcome, a +2 on the goal attainment scale, could be walking to a park that's further away, maybe a 25-minute walk. So it's important to match these goals alongside participation in activity because we're really aiming to measure function alongside the ICF's framework, which dictates that participation in activity is one of the components of function. So looking at the data from that was collected from this study, we see that both the patients in the dynamic stretching AFO group showed a goal attainment scale score of 0. So this means that they are still meeting their expected level of outcome. So this isn't a negative thing. The dynamic stretching AFO group, the serial casting group achieved scores of +1 on the goal attainment scale. So they were achieving outcomes better than what they were expecting from their treatment.
So to sort of put all of this data on the same page, I think it's important to note that while we don't see any clear trends emerging from the data, we did see improvements in all of our patients. So all the patients going through this protocol and going through this treatment did see improvements in their function, just in different areas. So like I said, with a sample size of 4, we're not really able to draw any conclusions or note any sort of specific trends, but we think that the data that we gathered with this sample size is quite good for a pilot study, and we're happy to see people carry it forward in the following years. I know there's some future students sitting here, get some ideas. So a few things that we wanted to run over as far as challenges, and then a couple of take-home messages. I think one of our biggest challenges, first and foremost, was our low recruitment numbers. Obviously, sample size of 4, I've said it a few times, but we were very, very happy to be able to get a complete data set, even with that low number. With the capstone style project, we did have a relatively short window for data collection, so I think that kind of plays into that. One of the big challenges that we came across with this data was the variability of timing between our pre and our post measures. So on our initial methodologies, we were hoping for a fairly firm 4-week follow-up for our post-treatment measures, but any of the clinicians in the room can attest to clinical reality. Sometimes those 4 weeks happens a little bit early or a little bit late, just depending on sort of what happens with your patients and what happens in your clinical day-to-day. So we did see some variability in that. And the other thing that we wanted to bring up as far as our outcome measures was the comprehensiveness of the 10-meter walk test. So the data that we got, it was great. We did see improvement in a couple of patients. Anecdotally, from the clinician who did our data collection, he noted that some of the patients, although they didn't improve in speed necessarily, did show better biomechanics when they were walking. So while the 10-meter walk test was really easy to implement and it does show good reliability and validity for overall walking, we think something like a visual gait score, something like the Edinburgh Gait Score, may be more comprehensive for future studies looking at these sort of outcomes. So the Edinburgh Gait Score applies a value to certain characteristics of gait, so you're able to better track specific moments in gait and sort of see from pre to post where changes are taking place rather than just a strict time. Couple take-home messages that we'd like to leave you with. First and foremost, obviously, future research is needed, as always in the P&O field, to be able to determine which stretching modality, if either, is most effective. But we are happy to see that this came away as a good start. And secondly, that we wanted to sort of leave to any of the clinicians in the room is the big thing that we took away from this is a clinical study can be integrated into your clinical practice with as little interruption as possible. So the outcome measures that we chose for this study, we chose on the basis that a lot of them were already used in clinical practice, they're quite easy to implement, and they don't require a lot of extra training. The goal attainment scale being sort of the exception to that, it did take a few extra minutes per appointment and required a little bit of skill and practice on the part of the clinician, but we feel that clinical practice, you can integrate research into clinical practice if you want to, with as little interruption as possible. So we'd just like to leave you with that.
So looking at future directions following this study, as Sydney had mentioned, our recruitment numbers were low, but we would like to continue to enroll participants for this study in the future. After speaking to a statistician who works at BCIT, she recommended that we achieve a sample size of about 30 participants before employing any statistical analysis on our data. And so as a pilot study, we were able to show that our data collection methods were effective, but in order to make any conclusions about this study, we'd like to see that number of participants, that sample size increase. In order to do this, it might be valuable to enroll additional clinics within the study protocol in identifying patients. So just the number of patients that meet our inclusion-exclusion criteria coming through the New West Spasticity Clinic might not be enough to to achieve a larger sample size in a timely manner. Sorry, guys. So it would be valuable to enroll some other clinics in the study. In terms of looking at spasticity management research in general, it would be valuable to look at a longer follow-up time for pre and post measures. So a lot of the research on stretching modalities investigates somewhere in that 1 to 6 month follow-up time, but it would be valuable to look at something more in the neighborhood of a year for follow-up once that botulinum toxin injection has worn off, to see if these benefits that we're providing to our patients are lasting. There are also many other stretching therapies used in practice. We focused on serial casting and dynamic stretching because they fall under the scope of orthotists, and they are commonly used at the New West Spasticity Clinic, but investigating other stretching modalities would also be useful. Finally, as you can imagine, the experience of using serial casting versus a dynamic stretching AFO is very different, both for therapists involved and for the patients. So employing a qualitative study investigating how patients see their treatment and experience their treatment using either one of these two methods would be useful, along with investigating how other therapists, for example, physiotherapists, how they see benefits to both of these treatments. So anecdotally, physiotherapists do really like the stable base of support, the heel-toe walking that a serial cast allows for. So it would be useful to see perspectives from all of the different stakeholders involved in this treatment. We'd like to thank all of the people that made this research project a possibility, and we'd like to welcome any questions you might have at this time.
We'd especially like to thank Carl Ganzert for doing all of our data collection.
All right, so welcome back, everybody. Hopefully you're all refreshed and energized and had a chance to network. So my name is Nathan Lowe.
And I'm Sue Anderson.
And we're both very happy to be here to present our capstone project to you this evening. So Sui and I aim to validate a somewhat new sensor technology to measure patient adherence with relevance to spinal orthosis treatment. So just a quick disclosure note, we did use proprietary software kindly provided to us by Hodgson Orthopedic Group. We received a research grant from BCIT for equipment that we used in our study. However, no monetary compensation was provided to any of the parties that were involved in our study. Here's an outline of what we'd love to present with you to you guys today. We really want to talk with you how we developed our topic, the rationale behind why we think measuring patient adherence is important, some supporting background literature connecting patient compliance and successful treatment outcomes. We'll go into different types of monitoring that's currently being used in research, and then we'll talk about our methodology that we use to validate this new tech. We'll share our findings, discuss some of our observations, and then we'll finish up with our final thoughts. So I'll pass it on to Sue to talk about our topic development.
Thanks, Nate. So this is just a visual representation of our topic development. Originally, Nate and I were interested in how to effectively measure brace compliance. So how can we actually do that? We did a research or literature search and review to see what kinds of sensors were available in an orthotic context. From there, we decided to compare two sensors. We'll discuss these two sensors and why we chose them later in the presentation. So the rationale for our projects include acknowledging that there are limited sensor options in the use of an orthotic context. So we didn't actually find a lot in the research. So we were interested to see if we could find an effective way to measure brace compliance. We also wanted to highlight the false positives from certain sensors that we are hearing about from clinicians. So we heard that certain temperature sensors were actually giving some of the clinicians false positives, which means that the brace or the sensor was measuring the brace being on or registering the brace being on when it actually wasn't. We also wanted to highlight the importance of objectively measuring patient compliance and how crucial it is during treatment. So that brings us to the question, Why is patient compliance important in the first place? So Nate will talk a little bit about that.
So through our literature search, we did find that So through our literature search, we did find that conservative orthotic bracing is considered as an effective treatment for scoliosis. In one of the studies that we looked at, they found a 75% success rate in delaying curve progression in their brace group, as compared to only a 42% success rate in their observation-only group. Another study that we looked at by Bronx and colleagues noticed that their compliant group, so people that wore their brace for over 20 hours per day, also showed less curve progression. So in this table that's populated with their research, we can see that in their compliant group with an N of 389, only 11 participants ended up needing surgery, where in their non-compliant group with an N of 108, 22 participants ended up getting surgery. So the researchers go on to state that their higher compliant patients had less risk of requiring surgery. So now that we've established a little bit about why patient compliance is important, let's talk about why objectively measuring patient compliance is important. A core issue surrounding brace wear is incorrect patient-reported compliance. Though not purposeful, wear time that's reported either verbally or written may often be inaccurate and in many times over-reported. In one of the studies that we looked at, the researchers found that their patients may overestimate their wear time by as much as 200%. So Sue and I think that sensor-based compliance measurement may address the issues of subjectivity and patient recall bias. It can provide an objective understanding of patient wear time habits, optimize treatments by educating patients, and potentially reduce error in any studies where brace compliance is a controlled variable.
So here are some of the types of compliance monitoring that we found in our literature search. So we found some studies that use pressure sensors, written logs, temperature sensors, and humidity sensors. We used the latter three in our study. I wanted to highlight the last point, so humidity sensors. We actually did find that in our literature search. However, the humidity sensor that they used was used as a secondary check sensor. So it was just checking to make sure that the other sensor that they were actually interested in wasn't being tampered with by participants. So it wasn't the primary focus of their study. So we still believe that humidity is a relatively new approach to brace compliance monitoring. So let's talk a little bit about the two sensors that we chose. On your left, you'll see the information about the I button. So it measures temperature. A large brace company in the United States is actually using the I button to measure compliance in their scoliosis braces. It was also present in some of the literature. Nate and I actually found that data collection was more difficult with the I button versus the wireless sensor tag, and we'll talk a little bit more about how we collected data from the sensors. On your right, you'll see information about the wireless sensor tag. So you can see that it measures humidity, and it's not reported in the literature besides that one study I mentioned where they used it as a secondary check sensor. It also has wireless data capabilities, so you can also access the data online, which can be a convenient aspect of using the wireless sensor tag. So here's a couple of pictures of the sensors we used. On your left is the I button, again the temperature sensor, and the wireless sensor tag, which is the humidity sensor. So in each of our LSOs that we developed for our research project, had both of these sensors internally molded into the inside, and I have pictures of the brace to show you later. So we'll talk a little bit about methods with Nate.
Thanks, Sue. So on to our methodology. 10 lovely participants over the age of 19 were recruited from the BCIT P&O clinical program.
Thanks, guys. Great participants.
Standardized non-corrective lumbar sacral orthoses were used in our study. They were all custom made from 3mm polypropylene and had anterior openings and a Velcro waist strap. I would like to add that all the fabrication of the orthoses was overseen by a very capable RTPO. The participants in our study were instructed to wear the orthoses for a minimum of 4 hours per day over our 2-week study period. They were asked to meticulously document when they donned and doffed their devices on a written log sheet that we provided with them, as well as keep track of any activities that they may have participated in while they were wearing their brace.
All right, so this brace might look familiar to some of you. So here's an internal and external view of the braces we used for our study. So it's a non-corrective LSO, measured about 5 inches by 15 inches. And we have a sample here if any of you guys are interested in looking at it after the presentation. And as you can see, the braces all had internally molded sensors. So this is how we collected the data from our sensors. On your left, up there, the white little router is called the Ethernet Tag Manager. So that's how we collected information from the wireless sensor tag. So that's the little square one. This is convenient because you can put the router in your clinic, or you can actually put it in your patient's house or somewhere where they frequent. So whenever their sensor is within range of the router, it'll pick up the data from the sensor or the brace. So this could be convenient. And then also the clinician can access this data that the router is picking up online. So they can just go from their clinic and look at when their patient is actually wearing their brace. So on your right, you'll see the USB I-button reader. So again, Nate and I found it difficult to use this sensor just because you actually have to physically take the sensor out of the brace to collect the data from it. So if you had it in one of your patient's braces, you would have to physically take it out and have them in the clinic in order to read the data from the sensor. So that could be a downfall of using the I-button.
Okay, so this table shows the total amount of data that was collected every 15 minutes during our 2-week period. Now, I do need to add that this was data that was collected 24 hours per day by each sensor, regardless of whether our participants were wearing their brace or not. So we collected 13,000 data points for the I-button. These are data points of temperature. Now, here's a sample of data that was collected from one I-button over a course of 2 weeks for one participant. So on the y-axis here, we see temperature ranging from 4 to 36 degrees, and on the x-axis, we have the chronological date. So wherever we see the data spiking is where we are seeing the temperature go above baseline. So this is indicating to us that the brace is being worn at that time. So for the wireless sensor tag, we collected 23,000 data points of humidity. Now the 10,000 data point difference here exists because initially we were collecting data every minute, but once we found this out, we changed it to match the every 15-minute data collection with the I-button. Here's some sample data from the wireless sensor tag that's taken from their web-based program. On the y-axis, we see relative humidity and percentage, and on the x-axis, we see chronological date as well. Now, this is for 5 sensors at the same time, and with the same concept, any of those data spikes that we see is when the humidity rose above baseline, indicating to us that the brace was being worn. So after processing all of the raw data, we were left with a total of 112 points of interest for the I-button and 56 points of interest for the wireless sensor tag. Now these are the data points that actually reached the threshold levels for both temperature and humidity respectively to indicate to us that the brace was being worn. Now the difference that we see here in analyzed data is due to some technical difficulties that we'll talk about in our limitations.
All right, so for our data analysis, we used a statistical analysis method called the Bland-Altman. So the Bland-Altman assesses the agreement between 2 different measurement methods. So in our case, it was the wireless sensor tag and the I-button that we were interested in. In our study, we needed a standard of true wear time. So we actually used a written log that was provided to each of the participants to represent the true wear time, so the time that they are actually wearing these braces that we provided them. Now, we realize that we just said that patient-reported compliance and them reporting it to us isn't necessarily reliable and sometimes over-reported. However, we felt that our participants recognized that they were being monitored and they were in a controlled environment, so we felt that their written logs would actually be a reliable measurement of true wear time. So back to the Bland-Altman, it assesses the agreement between the two measurement methods. So what we did is we took the data from the written logs and compared it with the data from the wireless sensor tag. Then we took the data from the written log and compared it to the the iButton data. So from there, we have two relationships that are circled in red there. And we wanted to see which one of these two relationships was the most accurate in measuring the true wear time.
So as Sue mentioned, this is a Bland-Altman comparison that's plotting the differences in brace-on minutes to the average of brace-on minutes between the written log and the iButton. So on the y-axis, we'll see here the difference in brace-on minutes. So we took the measurements taken by the written log minus the measurements from the iButton. And on the x-axis, we see the average of the brace-on minutes between the two methods. So this line that's going to pop up here indicates the 0 line. So if both the methods had perfect results to each other, all the data points would line up on this line. So anything above this line indicates when more minutes were on the written log, and anything below is when the iButton picked up more minutes. So we can see here from the scatter of data, it's mainly clustered around a mean of 16.5. This is telling us that from our experiment, we found that the iButton underestimates wear time by 16.5 minutes compared to a written log. Also, there's some pretty clear outliers here. So the ones above are when our participants recorded wear time, but the iButton didn't. So this is showing us that there were dropped data points. The ones below are when the iButton recorded wear times, but the patient log had no records of it. So this is indicative of the false positives that Sue had mentioned earlier. Another explanation for both these outliers could just be human error in data collection or analysis. So here's a Bland-Altman comparison between the written log now and the wireless sensor tag. So this is the same scale as the previous slide, but we can see a greater scatter variation in the data. The average here is 61 minutes, telling us that from our experiment, we found that the wireless sensor tag also underestimates wear time, but this time by a factor of 61 minutes as compared to the written log.
So in summary from our study, we highlighted that measuring compliance objectively is very important. We also found that the wireless sensor tag appears to be less reliable and less accurate in comparison to the iButton when measuring compliance. So again, the wireless sensor tag underestimated by 61 minutes and the iButton by 16.5 minutes. However, we want to highlight or enhance the point that both made underestimations, and there were limitations to our study that could have caused these differences. So some of these limitations include the short-term nature of our study, so it was only 2 weeks, and we used a small convenience sample, so not necessarily representative of the general population, and that leads us to limited generalizability. So we can't necessarily take the results and apply it to the general population. This is because all of our participants were in mostly a temperature-controlled environment, so they were sitting in class or they were in the lab walking around campus. Nothing too crazy, so their range of activities was actually not that great. So again, not totally generalizable to the general population. We also had some difficulties with our wireless data that we picked up from the wireless sensor tag, and Nate will talk a little bit about that further.
So the technological difficulties that we had revolve around the wireless data collection method. So the wireless sensor tag works in harmony with the Ethernet tag router. They have to be within range of each other, and they both have to be plugged in. So the wireless sensor tag can collect about 3 days worth of data. After that, it's maxed out, and then anything after that becomes lost. So during our data collection period, the Ethernet tag router was unplugged unbeknownst to us, causing us to lose a large sample of our wireless sensor data.
All right, so we have a few recommendations for future studies looking at objectively measuring patient compliance. We recommend using a larger sample size if possible, and perhaps a more realistic sample, so perhaps people that are actually wearing braces on a daily basis for their scoliosis. We also recommend looking at sensor settings and fine-tuning them. So by this, I mean you can change the frequency at which the sensors pick up data. So for us, it was every 15 minutes the sensors would pick up data. This can be changed to every 1 minute, every 5 minutes, etc. So playing with these settings may change the results of the study. We also recommend looking into using these sensors in other devices, so not necessarily just scoliosis braces. They could potentially be used in perhaps stretching orthoses like Jordan and Sydney talked about, and possibly cranial remolding orthoses, which Chris and Chloe will talk about later. Despite our results and that the wireless sensor tag appeared to be less accurate than the I button, we still believe it has the potential to measure patient compliance. And we believe that further research is required to determine whether this is actually the case or not. So as clinicians and researchers in this room, what we want you to take away from our research is that objective compliance measurement can help provide better estimates of actual wear time. It can validate the brace treatment that you're providing for your patients in clinic. And overall, it can optimize patient outcomes. And we'd like to thank the following people for helping us make this project happen. We couldn't have done it without you. Thank you so much. Thank you. We'd like to open the floor to any questions you may have.
Great. Thanks again, everybody, for coming out. We're excited to talk to you about our research project. So my name is Chris Bennett. This is my research partner, Chloe Plekash. And tonight we're going to be talking to you about investigating the efficacy and parental satisfaction of 3D printed cranial remodeling orthoses. So just to give you a brief outline, we're going to give you a brief introduction to what we decided to research on, why we decided to research 3D printed cranial remodeling orthoses, the methods that we use to look into these orthoses, the results we found, the conclusions we drew from these results, and then we'll also have a brief time open at the end for some questions as well, just like the previous 4 groups. As another disclaimer, we would like to say that we did not receive any financial or commercial return from our involvement in this research. We were purely observational. So with that, I will hand over the floor to Chloe.
So, before we take this any further, I want to clarify some important terms, mostly because my parents are here and I want them to understand what's going on. So, in general, a positional cranial asymmetry is a head-shaped deformity due to repetitive pressure on a given area of the skull. So when you think about babies, they're a bit of a perfect storm for this because they have soft skulls, they spend a lot of time sleeping, their heads are on their little mattresses or in contact with carriers or they're in car seats, etc. So they spend a lot of time with contact on their skulls. More specifically, one type is called plagiocephaly, and this is when one side of the back of the head becomes flat. Often, the forehead of the same side will boss forward, so it sticks out a bit, and the ear on the same side will move forward as well. Another type is called brachycephalic, and this is when the entire back of the head gets flat. But what can be done about this?
Okay. So to give you a bit of an idea of the process of treatment, if a child is diagnosed with positional plagiocephaly or brachycephaly, they often get referred to starting with head repositioning. This is where the parents are counseled to watch which side the baby tends to favor. So, for example, if the child likes to lie on the right side, chances are the right side is getting flattened. So the parents are advised just to adjust the child's head to the left side to try to even that out and contradict that other side. If that doesn't work, they're generally then referred to physiotherapists who do their magic. And if their treatment isn't severe enough to treat the child, they then move on to an orthotist who will give them a cranial remodeling orthosis. And just for terms of definitions, the head repositioning and physiotherapy are considered conservative treatments. So, looking at conservative treatments alone versus a cranial remodeling orthosis. Why would you go towards a cranial remodeling orthosis? So, currently, research suggests that CROs resolve positional plagiocephalies and brachycephalies better and faster than just conservative treatments alone. And they're also seen to be more beneficial, especially in severe cranial deformities. But there are some drawbacks of using these CROs. So for example, some research has found that using CROs causes personal strain to parents of affected children. So for example, there's a lot of social stigma that comes with seeing your child in a helmet. So there's some concern. The parents often get asked questions. Why is your child like that? Is there a problem with your child? And the parents also find there's some concern in the interference of the helmet in the child's day-to-day life. So being able to breastfeed, being able to have that skin-to-skin contact, whether or not their head's being pushed forward in their car seat. So parents' concerns generally tend to be around that they are perceived as thick, they're perceived as heavy, and they're perceived as poorly ventilated and can cause some sweating. So our question was, could 3D printed CROs minimize these issues that parents have concerns with? And with that, I will hand you over to Chloe to tell you about 3D printed CROs.
So we're going to do a little comparison here and look a little further. As you can see on the left, there's the 3D printed option, and on the right is the conventional one. If you can see those numbers at the bottom of the scale, it's okay if you can't, but you'll notice that the 3D printed one is about half the weight of the conventional one. As well, they're substantially thinner, and this may make it easier for a baby to fit into their car seat. So here we see they're, again, less than half the thickness. So that's quite significant on a little head. As well, 3D printed has the potential to be better ventilated. Now, these 3D printed CROs are still made out of plastic, just like the conventional ones. So it's not that the material itself is more breathable. However, you'll see on this helmet, there's a lattice design. And this structure allows better airflow. So it's this lattice design that can allow the device to be more breathable. And this sort of a design would be pretty well impossible to create with conventional manufacturing methods. So it's really 3D printing that's allowing this to occur. And a smart orthotist, but it's a side note. So all of these benefits, they sound great, right? However, we still need to remember what the goal of a CRO is, and that is to correct a head shape asymmetry. So for all of these benefits that I've mentioned to actually be important, the CRO still has to do what it's supposed to do. Unfortunately, to our knowledge, there is no peer-reviewed research on 3D printed CROs. Anecdotally, the orthotist who is using them notes really, really great outcomes. However, again, there's no data to refer to, so that's sort of what brought us to this topic as our project for Capstone.
Okay, so knowing that there was no research done, our questions were, do these 3D printed CROs work, and are parents satisfied with the outcomes in the treatment? So we set out to measure heads and determine the change in shape using a clinician to do all of our work for us, and then to check parental satisfaction with a survey that we delivered once parents had finished their treatment. So to explicitly state the purpose of our study, we set out to determine the effectiveness of these 3D printed CROs in treating plagiocephaly, brachycephaly, and then to examine these parental satisfactions with the 3D printed CROs. So just a note on 3D printed manufacturing. 2 years ago, a best practice study was performed at BCIT. So those of you who attended this symposium 2 years ago might remember Shane Bates and Jeff Wright. And they talked about whether or not it was possible to actually 3D print a CRO. And they found that it was actually an excellent method of creating a CRO. So that being said, to our knowledge, there is no published peer-reviewed data around 3D printed CROs, but there is on other CROs. So to go into more methods, I'll give you back to Chloe.
So enjoy this cute little photo. For our study, digital scanning was the method of choice for head shape capture. And this baby looks like he's totally having a fine time and not at all concerned about the scanning that's occurring. And you'll see here that these digital scans produce data files, and those data files allow us to calculate various measurements. So here we can see on the right is the initial scan, and on the left is the final scan. And this is the information that's gathered through a digital scan. And so from this way, you can see how the head shape has changed. And it may be hard to see from the back, but there is some change in the bottom left corner there. There are important measurements used to quantify the degree of head shape asymmetry. All measurements are taken from a transverse plane at the level of that gray line on the baby's head. So imagine that gray line continues through the head of a head scan, not of the real baby, but imagine this gray line continues through the head, and that you'd be looking down on that slice in the transverse plane. And that's where all the measurements are taken. One of the important measurements is the Cranial Vault Asymmetry Index, or CVAI. The CVAI is used to measure the severity of plagiocephaly. To calculate it, 2 diagonals are measured. Each is 30 degrees away from the midline. And in this equation, you'll see that D1, or diagonal 1, is the longer of the 2 numbers. For brachycephaly, we use the cephalic index, and it is simply the width divided by the length times 100. And for both of these measurements, the larger the number, the more severe the head shape asymmetry. So the CVAI and CI are commonly used in the literature to indicate head shape severity. However, there is a huge range in the CVAI or CI values used to define treatment success in these studies. So that can be quite frustrating when you're reading them. Furthermore, there is no consensus on what CVAI or CI indicates that helmet treatment should begin or should end. So, since there's no standardization, we had to create our own working definition of what treatment success meant for this study. And that led us to the Pharmacare Values. Da, da, da. In BC, Pharmacare sets criteria to indicate how severe a child's head shape asymmetry should be before they get helmet treatment. So, if a baby's head measurements meet these criteria, they are automatically pre-approved to begin helmet treatment. Now, I know, some people in the room maybe don't love Pharmacare, and maybe they don't think that Pharmacare is the be-all and end-all, and we would agree with you. But they do heavily influence which babies in BC end up getting CROs, and thus, they also influence the type of head shape data we're going to get. So, we really had to include it in some way. As well, we also hoped that these numbers would be relevant to clinicians since they would be seeing it in their daily practice. So, because of all that, we decided that a treatment would be successful when the final head measurements no longer qualified a baby for helmet treatment as outlined by those Pharmacare values. Of course, this is not a perfect definition of success, but we needed some numerical cutoff point so we could count how many babies had successful correction and how many did not. So here we have a sort of visual of our study procedure and timeline. And really, we only got involved once the whole treatment was done. So they would come in for their first head scan, they would get their helmet, they would begin treatment, and then once everyone was happy with the head shape, they would have their final head scan and the treatment would be over. And that's where we would come into the picture. So we would get parental consent to use the head scan data, and we would also ask the parent to do the parental survey. Of course, the parent could refuse either of those, could just give consent or just do the survey, but we would ask them to do both. Looking into the head scan participants who we did have, there was a total of 8 of them. 5 were male, 3 were female, 5 had plagiocephaly, 2 had brachycephaly, and 1 was a combined presentation. The results. All the patients had successful shape correction based on our definition of successful treatment. So that was exciting news. There was also a statistically significant difference between start and end CVAI values for plagiocephaly patients at a p-value of 0.03. So that was exciting because there's only 5 plagiocephaly kids in that group. And now on to survey methods.
Okay, so I'm going to talk to you a little bit about the survey methods that we used to ask the parents what they thought. So in total, we received 9 surveys altogether. However, 2 were incomplete, so that left us with an N of 7. So our survey was comprised of 27 questions, 25 of which were closed. However, these closed questions did have the option to elaborate a little bit on your answer. And we also had 2 open questions that allowed them to talk about what they liked about the treatment, things they would change, just kind of like an open forum situation for them to be able to express their thoughts. So our questions included topics such as the sources of information that they were getting their information from regarding CROs, their experience of using the CRO from the clinic that provided the 3D printed version, and the post-treatment satisfaction of the parents. So looking at this graph, what we see is the majority of parents, before they were referred on to get a CRO, were getting their information from the internet, which is interesting. So the most popular answer was the internet. Second most popular response was no knowledge. So parents were either getting their information from the internet or oftentimes just didn't have any information whatsoever. Some of the other parents reported that they were getting information from their physiotherapist, from a family friend, or from other. However, the person who reported other did not specify what that other source was. So moving on to knowledge of CROs post-referral, we see a big jump in where they're getting their information from. So parents ended up moving on to getting information from the internet primarily and the physiotherapist. So these two were tied for their primary sources of information. Next was their family physician, and then coming in the bringing up the end of the pack is the orthotists, the pediatricians, and the family friends. Because this is a P&O symposium, we just wanted to draw attention to the fact that only one person reported that they were getting any information about CROs post-referral from an orthotist, which we thought was interesting. So we also asked them what their reasons for choosing a 3D printed CRO was, and we gave them a bunch of options and told them they could pick as many as applied. So we see here that the major concern for parents in choosing a 3D printed CRO was the weight. They were concerned that the child's head or the child's musculature was not going to be strong enough to support other helmets. So moving on, thickness was also a big concern. So as I talked about, the ability for a child to be able to sit in a car seat without their head moving forward, to be able to interact with the environment due to that thickness, did come up in our survey. So the third most mentioned thing was appearance. So obviously some aesthetics come into play here, which is also interesting. We also note that one did not deliberately choose this clinic for 3D printed CROs. And also one listed other, but again did not specify their reason for selecting other. So some more key points from the survey. Parent knowledge of CROs is gathered primarily online altogether, which is really interesting. 4 out of 7 chose the clinic that they chose specifically because they offered 3D printed cranial orthoses. 7 out of 7 would choose 3D printed cranial orthoses again over conventional CROs or physio. 7 out of 7 would be very likely to recommend a 3D printed CRO to another family, and 7 out of 7 were really satisfied with the total head shape improvement. So for more conclusions, I'll give you to Chloe.
Okay, so based on our data, these are our conclusions. The 3D printed CROs seem to correct head shape very, very effectively. There was also a significant change in head shape for the plagiocephaly group. From our survey information, we found that parents were very satisfied with 3D printed CROs and may have chosen them because they're thinner and lighter. Parents also seem to get a lot of their information from the internet. And now on to some of our suggestions.
So I know we're kind of harping on the internet right now, but that's the biggest thing that we felt really came from the study in terms of what we found in the surveys. So coming out of this, we really recommend that there's a need to provide evidence-based information on P&O websites and even on business websites so that parents can make well-informed decisions. So we know that parents are already concerned for the well-being of their child. There's a lot of misinformation on the internet, and we just feel that bolstering good, solid research, bolstering the internet with that kind of accessibility really provides the best opportunity for parents to make proper decisions, not always necessarily to go after a 3D printed CRO, but to make good, healthy decisions based on the welfare of their child. So, as all studies, ours did have some limitations, so there was the potential for some biases here. In the open questions, we found that the parents generally reviewed the clinician very highly, and they often talked about the clinician and the experience of the clinic. So there is the potential in that for them to look more highly on this form of treatment because they like the clinician. So we identified that as a potential bias. We also did have a low number of participants and no control or comparison group. And as mentioned before, with us reverting to or going after Pharmacare's values, there isn't really a standardized definition of a successful treatment. There aren't really solid parameters, so we had to get the best available parameters based off the information that we had. So based on these limitations, we do have some further research directions we would love to see this project go. We'd love to see it performed with more participants and more clinicians to eliminate some of those biases and be able to make it more applicable to a general population. As it stands right now, our study cannot be, you can't make the statement that it's as good, better, or worse than conventional CROs. So because of that, we would love to see the same research done, however, with a conventional compare group to be able to make those kind of comparative statements to see if, in fact, 3D printed CROs are as good as what's on the market or better. With that, we would like to give some special thanks to those who helped us out with our project. We really couldn't have done it without them. And to wrap things up, we'd like to open the floor for some questions.
Great. Okay, thanks so much, everyone. Last presentation. We did it. So I'm Leah Campbell.
And I'm Adriel Lau.
And our capstone presentation is on how infill percentage affects the ultimate strength of 3D printed transtibial sockets. So a quick disclosure, Barber Prosthetics kindly printed all of our sockets that we used in the project, and then also Daryl spent a lot of his time on our project as well. So thank you very much. A quick outline, we're going to give you guys a bit of background information into 3D printing, as well as developing our project, the testing process, and some results and future directions. I'll now pass it over to Adriel to give you a bit of that background information.
So 3D printing itself has been around for about 30 years, but only recently has it been getting more and more attention in the field of prosthetics and orthotics. We see many practitioners using this method because it is found to have a high degree of accuracy when it comes to adjustability, and the primary data is normally not lost. Because of this, we see this being used as an alternative option to traditional methods. So some examples are going to be put on the screen that are 3D printed devices. So first we can see prosthetic devices for upper limb amputees. We also see 3D printed cosmetic covers. And as Chloe and Chris mentioned in their presentation, we also see 3D printing being used in cranial remodeling orthoses. So when looking at these examples that I put on the screen, it's important to keep in mind that none of them are weight-bearing. So if we are to use 3D printed sockets for lower extremities, it is important that we perform strength testing in order to deem them safe for patient use. So this next slide is to give a brief overview of the process of 3D printing. And this is going to be fairly specific to the field of prosthetics and orthotics. So first, we have the scanning method. And this is typically done with a handheld scanner, and this is to digitally acquire a shape such as a residual limb. That data file is then stored on a computer, and this is where computer-aided design can take place. And this is where the model is digitally rectified. After that, we can see a slicing process, and this is where the user can customize and optimize each setting to their choosing. Next, 3D printing takes place, and this is where the printer or the structure is physically printed. And there are various types of 3D printing out there. There are such as fused deposition modeling and selective laser sintering, for example. Afterwards, we can see a finished product being created.
So there are a lot of different parameters that you can manipulate that will alter the characteristics of the object that's being 3D printed. I'm going to use a cylinder that was created in the slicing software that Adriel was talking about, just to give you a couple examples on different parameters that can be manipulated. The first parameter that I'll talk about is layer height. This fairly intuitively is the height between each layer that the printer lays down. And you can see from this picture that they're quite small values. So listed here is between 0.1 and 0.3 millimeters. This can affect the print time in that a very small layer height will take a long time for an object to print, and it will also affect the smoothness or the finish of the product. Wall thickness is the number of shells on both the inner and outer walls, and these can be the same number of shells or different numbers. That can affect the strength properties of the socket as well as the print time. Infill percentage is the amount of material between each of those walls. 10%, as you can see here, is very little material between those walls. 25, a little more. 40% even more. So just from the 3 examples that I've mentioned here, you can probably deduce that all 3D printed objects are not created equal. So if we're going to be 3D printing sockets as clinicians, it's pretty important that we decide which parameters we should be manipulating and which values we should be using for these parameters. So that's how we decided to test the strength properties of sockets based on different parameter manipulation. Adriel and I originally wanted to manipulate many different parameters and the relationship to each other and strength, but due to the short time constraint and the cost of doing this, we were only able to manipulate one parameter. We chose infill percentage because we know that it has a direct relationship to the print time of a socket, and we hypothesized that it would have a direct relationship to the strength properties of the socket. So we chose to go with 30, 40, and 50%, as you can see here. We chose these values because at the time, a company in North Carolina was printing diagnostic sockets at 40% infill, so we wanted to test to see if those were strong enough to actually be on patients. And then we wanted to go 10% above and below to test their relationship to strength. The ISO 10328 is an international standard that dictates how the strength requirements for lower extremity prostheses, including sockets and componentry. In order to adhere to these standards, componentry and sockets have to undergo cyclic and static testing. The cyclic testing takes over a year of continuous testing, so we chose to go with static testing. We also chose to test at initial contact, and the P5 weight class, which refers to patients that are less than 100 kilograms. This diagram here on the right shows the coordinate system from the ISO standards that ensures that everything that's being tested is tested at the exact same orientation, so everything can be compared. Based on all these conditions, the threshold that had to be overcome by the sockets was 4,480 newtons. And just for a bit of reference, that's approximately 1,000 pounds or the weight of a horse.
So in terms of methodology, we had a lot of components that were involved in our project. So the next few slides are going to talk about each component step by step. So first, we have our sockets. As you can see here, we have an example of a socket at the front here. So we had a sample size of 9, and they were all identical in that they were all printed from the same data file. So as you can see on the board, we printed 3 sockets at 30%, 3 sockets at 40%, and 3 sockets at 50%. We also chose these percentages because we thought they would best represent percentages that clinicians may decide to print in the future. So next we have a table that illustrates some of the statistics that were gathered from each socket. So in the first 3 rows, you can see our sockets that were at 30%, the ones at 40%, and the ones at 50%. So we wanted this table to illustrate the consistency between each socket. And you can see they are quite similar in terms of length, but there is some discrepancy in the weight. You can see that the 50% sockets were slightly heavier, and we're not entirely sure how this came to be, but this is definitely an area that can be done for further research. For the printer, we used a fused deposition modeling printer located at Barber Prosthetics. This printer took about 8 to 9 hours to print per socket. For the socket itself, they were all printed from the same data file, and this data file was supplied by the company Additive OP down in Charlotte, North Carolina. So all the sockets were printed from a white polylactic acid filament, which is a type of plastic. They were all reinforced with Scotch cast, and they all had a wood block attached at the distal end. This served as our attachment point for our pylon and the rest of our strength testing apparatus. Just to make a note, all the sockets were finished by the same registered prosthetic technician, and they're all printed from the same file. So for our strength testing apparatus, the machine was conveniently located in the materials department here in BCIT. And how this jig works, it compresses an object in the middle there, and that compressive force is then measured in newtons, which can be read on a digital monitor on the side. So this picture shows our socket in the strength testing apparatus. So just for orientation, on the right side of your screen is the anterior or the front part of the socket, and the left side of your screen is the posterior or the back of the socket. So at the top here, we see the upper plate. This allows our socket to be placed in the proper orientation. As Leah mentioned before, we're testing at initial contact, so this allows us to place it in that orientation. Next, we have our high-density urethane model. This model was fabricated directly from our socket shape, and this was to ensure an appropriate fit with our socket. Next, we have our socket, which was switched out after each test. And next, we have our stainless steel pylon. Because prosthetic componentry such as tube clamp adapters and pyramids have already been tested to ISO standards, we wanted to effectively eliminate those from the equation and test the socket itself. And this was only possible by recreating a one-piece stainless steel that acted as our pylon. Next, we have our bottom plate, which completed our setup. Next, I'll hand it over to Leah, who will talk about our testing process.
So using the jig that Adriel was just mentioning, we compressed the bottom and top plate to compress our socket. We underwent this compression until we reached the threshold force of 4,480 newtons, and we held it there for 30 seconds. The socket either failed or didn't fail. If it did fail, that was the end for the socket, and we recorded those results. If it did not fail, then we continued to compress until it did reach failure, and then we recorded that. A failure was defined as either 1 centimeter deformation or a crack in the socket. So we have a video for you of a socket being tested. We fast forwarded till the end, and to orient you, this is the posterior side over here. Yeah, a socket breaking. Okay, so the results that we recorded from this test was whether or not it passed that threshold. If it did pass the threshold, then what force did it eventually fail at? And then the area of the socket failure. So these are the results that we got. You can see on the bottom here is our different infills of sockets and the force in newtons that the failure occurred. They all surpassed the 4,480 Newton threshold, and with the exception of one socket, they were all double the threshold, which is 2 horses for anybody who's keeping track. Yeah, so they all passed the threshold. The areas that the failure most often occurred in were the medial popliteal region, with 7 of the 9 sockets failing there. 2 of the 9 sockets failed in the middle lateral part. One of the second socket that failed at the fairly low number compared to the others was one of these in the middle lateral region. Adriel will now discuss these results.
So in terms of our discussion, and based on our results, we can see that all the sockets passed ISO standard 10328. So from this, with our specific criteria of static testing, initial contact, and P5, it would appear that these sockets would be safe for patient use. Next, surprisingly, infill percentage did not appear to influence the strength of the socket. We found this to be quite interesting as we anticipated perhaps a trend, whereas a larger infill percentage might result in a larger force required to fail. Next, we observed all the sockets failed at twice the required force, with the exception of socket number 2 that Leah mentioned earlier. And lastly, all the breaks occurred above the Scotch cast. This is quite promising as diagnostic sockets are usually reinforced to create that added strength. So seeing that break occur above that was good news. So in terms of limitation, much of our project was limited by cost, time, and resources. As I mentioned earlier, we only had a sample size of 9, which is quite a fair small sample size. So we would have liked to create more sockets to create a statistical analysis of some sort. Next, we only tested one parameter. We wanted to isolate the effects of infill percentages because we want to see how that specific parameter affected the strength of the sockets. And lastly, with 3D printing being a relatively new concept in P&O, there was a lack of literature available. Because of this, this created some challenges in narrowing down our methodology and our procedure in general. So in terms of future directions, this mirrored some of the limitations I spoke about earlier. As with much of P&O, there is definitely more testing needing to be done. We would like to explore other parameters, as Leah mentioned earlier. This would allow us to isolate how each parameter affects their strength on the socket. Our project also focused on very specific conditions set by ISO standards. The ISO standards outline cyclic testing, P3, P4 conditions, for example, and in order for a 3D printed lower extremity socket to be safely used by a patient, all of these requirements need to be met. And lastly, our project was quite dependent on the technology at the time. With the technology of 3D printing advancing at such a high rate, it would be interesting to see how different materials, different printers, and even different methods of printing can influence the strength of a 3D printed socket. Lastly, we just wanted to mention that this project is just a small piece of a much larger picture. We had a lot of fun working with clinicians and technicians, and we were very grateful that we were able to be a part of it. We hope that our findings contribute to a much larger 3D printing project in the future, but also to the profession as a whole whenever the conversation of 3D printing arises. Thank you.
So this concludes the evening, and I really want to, first of all, thank this class for all their hard work and putting on a great night for us to enjoy. So thank you very much, class. I do want to say that they honestly have been fantastic to work with. So very high on the internal motivation scale with this group. And I also want to thank Caroline, because I know once in a while the whip had to come out. She had to crack it a couple times, but overall very well guided and internally motivated group. So fun to work with and great project. So thank you guys. And it's kind of always an interesting time of the year because we're pretty much saying goodbye, right? And and so we're going to miss you guys. You've been fantastic, and but you guys know where we'll be in 2 years from now. So come on back and do it all again. And lots of people to thank that have been involved. So like we say, it takes a village to raise a family like this, and so you can see a small sampling of the people that have been involved in making these projects a success and our evening a success. And so definitely hats off and thank you to the folks at Barber and Hodgson's and the Spasticity Clinic and our Head Shape Clinic, and OPC is very good at sending out emails apparently to select people, and that's good. And the Carey Center, which is across the street, which is our BCIT Applied Research and Innovation Center, are always willing to help and always excited to work with us, so that they're a key player in ensuring that we're successful and moving forward. And of course the class. And you guys as well, got parents in the group, thank you for making the trip in from wherever you came from and different provinces, and to support your sons and daughters and families to make sure that it gets done. I even heard of a mom transcribing as part of the So thank you very much, you all. It's been a pleasure, and we hope you enjoyed the evening.